Welcome back to the deep dive. Today we are stripping away the colloquialisms from a word that everyone uses. But according to this stack of medical texts and research papers on my desk, very few people actually understand. That word is shock.
It's a word that carries a tremendous amount of cultural baggage, doesn't it?
It really does. In the real world, shock is an emotion. It's what you feel when you check your 401k during a recession or, when you see the season finale of a thriller.
Surprise. Trauma.
Exactly. But we aren't talking about feelings today. We are talking about the medical definition. We're talking about a plumbing failure so catastrophic that it threatens to crash the entire human system in a matter of minutes.
And that distinction is the most important place to start. In the intensive care unit, or in the back of an ambulance, shock isn't a feeling. It's a specific state of being.
A measurable state.
A measurable physiological crisis. If we want to be precise, and the source material today is incredibly precise, shock is an acute state where the cardiovascular system simply cannot pump enough blood to the critical organs to keep them functioning.
It's the ultimate engine failure.
It is. And the stakes are, well, they're binary. We're diving into the pathophysiology and management of shock today, and the literature is blunt. If therapy isn't optimal, shock leads to death.
No middle ground.
There is no middle ground. The cells either get oxygen or they die.
So before we get into the mechanics of how the body falls apart, and frankly the ruthless, almost violent way it tries to save itself, we need to define the line in the sand. I think a lot of listeners might assume a doctor just, looks at a patient and says, oh, they look pale, they must be in shock.
Yeah, it's much more technical than the eyeball test.
Yeah.
We have hard numbers here. Clinically, shock is defined largely by blood pressure.
Okay.
Specifically a systolic blood pressure, that's the top number, dropping below 90 millimeters of mercury.
Below 90, that is low.
It's dangerously low. But there's a caveat in the text that I find fascinating, and it's one that catches a lot of people off guard.
What's that?
It's not just about the absolute number. It's about the drop relative to the patient's baseline. The definition also includes a drop of 40 millimeters of mercury from their norm.
Okay, so let's play that out. If I'm walking around with high blood pressure, say I'm a hypertensive grandma running at 150 systolic, and I suddenly drop to 110.
To a paramedic or a casual observer, 110 sounds great. It sounds textbook normal.
Right.
But for you, or for that grandmother, that is a massive crash in perfusion pressure. Your brain and kidneys are calibrated to 150. If you drop to 110 rapidly, you could be in profound shock, even with a normal number on the screen.
That's a critical insight right off the bat. It's relative to the individual engine, not just the fleet average.
Precisely. And this drop has to be accompanied by what we call perfusion abnormalities.
That's the fancy way of saying blood isn't getting where it needs to go.
Right. Even after we've tried to fill the tank with fluids.
So our mission today is to unpack the physiology of this crisis. We're going to look at the three culprits, the different ways the plumbing breaks. We're going to analyze the body's biological triage system, which I found to be absolutely brutal reading through the notes. And finally, we're going to get into the high-stakes chemistry used to reverse it.
The pharmacologic warfare phase.
Exactly. So let's start with part one, the engine failure. The source material keeps coming back to one concept: oxygen delivery versus oxygen consumption.
This is the fundamental equation of life. Every cell in your body is an engine. It needs fuel oxygen to run.
Okay.
In shock, the delivery system fails. The circulatory system cannot deliver sufficient oxygen to meet the metabolic needs of the tissues.
But here's the thing that caught my eye in the reading. This happens even if the body's oxygen consumption is normal. It's not that the body suddenly needs more.
No, it's that the supply chain is completely collapsed.
The demand is static or maybe a little elevated due to stress, but the tissues are just starving in real time.
They are. The delivery trucks have stopped running. And when we look at why those trucks stop, we categorize the causes into three main buckets.
The three culprits. Let's break these down because I think this clarifies the different flavors of shock people hear about in medical dramas.
Okay, so the first culprit is hypovolemic shock. Think of this as the empty tank scenario.
Okay. Not enough fluid in the system.
Right. The pump works, the pipes are fine, but there is simply nothing to pump.
The second.
Cardiogenic shock. This is the broken pump. The heart muscle itself fails, maybe from a massive heart attack or acute heart failure, and it simply cannot generate the pressure required to move the blood.
Even if the tank is full.
Even if the tank is completely full.
And the third.
Vasodilatory shock. Now, this is the tricky one. This includes septic shock, anaphylactic shock, or neurogenic shock.
Okay.
In this scenario, the tank is full and the pump is working fine. But the pipes, the blood vessels, have expanded so drastically that the pressure bottoms out.
I like the garden hose analogy for this. You have the spigot on full, but suddenly your garden hose expands to the size of a sewer pipe.
Yeah,
The water just trickles along the bottom. You can't generate any spray pressure.
that is a perfect visualization.
Yeah.
The volume is lost to the massive space created by the dilation. The plumbing has become too big for the liquid it contains.
I want to double click on hypovolemic shock the empty tank. I think when most people hear that, they just think bleeding, trauma, car accident, gunshot wound.
And hemorrhage is the classic example, certainly. That's an external loss of whole blood.
Right.
But hypovolemia, which just translates to low volume, can be insidious. It happens in burn victims. When you burn a large surface area of skin, you lose the barrier that keeps moisture in. You literally evaporate your blood volume into the air.
That is a horrifying image.
It is. It can also happen from severe vomiting or diarrhea, or, and this is surprisingly common in the hospital setting, over-aggressive diuretics.
Diuretics, so the drugs that make you urinate.
Exactly. If we give a patient too much medication to make them urinate, say trying to treat heart failure, we can accidentally pee them into a state of shock.
And then there's this concept of internal redistribution. I found this difficult to wrap my head around initially. The fluid is still inside the body, but it's not in the veins.
Exactly. We call this third spacing. Imagine a house where a pipe bursts inside the wall.
Okay.
The water is still inside the house. It hasn't flowed out the front door, but it's not in the plumbing where it's useful. It's soaking into the drywall and the carpet.
Ah, I see.
In the body, fluid leaks out of the blood vessels and into the soft tissues. The patient looks swollen and puffy, but their veins are technically dry.
So they are drowning in fluid, but their blood pressure is at 0.
That's the paradox. And this connects to a concept called relative hypovolemia. This is the bridge between the empty tank and the wide pipe.
Walk us through that.
Okay, take someone with sepsis, a severe infection. The inflammation from the infection causes their blood vessels to dilate massively.
Right, the wide pipes we talked about.
Exactly. So suddenly, the 5 liters of blood they have, which was perfectly adequate 5 minutes ago, is nowhere near enough to fill this new expanded container.
So even though they haven't lost a single drop of blood,
Relative to the size of their vascular system, they are hypovolemic. They are empty just because the container got bigger.
that's a crucial distinction for understanding treatment later on.
It is. Now, regardless of why the pressure drops, whether it's the empty tank, the broken pump, or the wide pipes, the body's reaction is consistent, and it is violent.
This is the part I labeled the sacrifice in my notes. It reads like a horror movie script,
It's an apt name. The moment blood pressure falls, the sympathetic nervous system kicks into
a
overdrive.
fight or flight system.
Right. And it activates the renin-angiotensin system. These are chemical alarms screaming vasoconstriction.
Squeeze the pipes.
Squeeze the pipes. But the body is smart about it. It knows it can't squeeze everything equally. It creates a hierarchy of survival. It decides instantly that the heart and the brain are the only 2 organs that are non-negotiable.
So, sorry kidneys, sorry gut.
Exactly. The body clamps down on the blood vessels leading to the skin, the skeletal muscles, the kidneys, and the gastrointestinal tract. It effectively shuts them off.
And it redirects all that limited blood flow to the center.
All of it, to the central corridor, heart and brain, to keep the lights on and the pump moving.
This explains the physical appearance of a shock patient, doesn't it? The classic signs.
Yes. Why are they pale? Because there is no blood in the skin. Why are their hands cold and clammy? Because the body has pulled the warmth of the blood into the core. It is stealing from the suburbs to save the capital city.
But there's a massive cost to this stuff.
The cost is that the suburbs begin to die. The kidneys, the gut, they become ischemic. They aren't getting oxygen.
And when human tissue doesn't get oxygen, it has to switch its metabolic strategy.
It moves from aerobic metabolism using oxygen to anaerobic metabolism.
And the byproduct of anaerobic metabolism is.
Lactic acid.
And this creates a vicious cycle.
The death spiral. Severe lactic acidosis develops. And here is the supreme irony of shock. Acidosis causes localized vasodilation. The acid buildup essentially paralyzes the smooth muscle of the blood vessels, forcing them to relax.
Wait, so the body is trying to squeeze the vessels to keep pressure up, but the waste product of that squeezing is forcing the vessels to open back up.
Correct. The body's attempt to save itself creates a chemical environment that makes the cardiovascular collapse worse.
Wow.
And once that cycle takes hold, squeeze, starve, acid, dilate, drop pressure, squeeze harder, it becomes very, very difficult to break.
Which brings us to part 2, detection. If we want to stop the spiral, we have to catch it early. If I'm a clinician standing at the bedside, or even a family member, what am I seeing before the patient hits that death spiral?
Before the blood pressure completely tanks, you see the compensatory signs. The body is struggling. The patient will be anxious. That's the brain sensing a threat, a primal fear.
Thirsty, right.
Very thirsty. Yeah. It seems so basic, but it's the body screaming for volume. It's the brain pulling the fill the tank lever. They might feel weak or lightheaded.
But if you want a hard number, you said, look at the kidneys.
Look at the kidneys. We mentioned they get sacrificed early. Urine output plummets. The source material specifies scanty levels, less than 0.5 milliliters per kilogram per hour.
Basically nothing.
Almost nothing. And the urine that does come out is dark, concentrated yellow. The kidneys are hoarding every molecule of water to keep the blood pressure up.
Okay, so anxiety, thirst, no pee. What about the vital signs? Aside from the low blood pressure, what else moves?
The heart rate spikes. Tachycardia, usually greater than 120 beats per minute. The pump is trying to compensate for the low pressure by cycling faster.
Just trying to maintain output by sheer speed.
Right, and breathing gets fast too. Tachypnea, over 30 breaths per minute.
And that's not just panic.
No, it's actually a compensatory mechanism for that acid we talked about. The body detects the metabolic acidosis in the blood and tries to blow off carbon dioxide to balance the pH.
That's fascinating. So the fast breathing is a chemical balancing act.
Exactly. It's respiratory compensation for metabolic failure.
Now let's go into detective mode with the lab work. We draw some blood. What are the clues hiding in the chemistry?
Sodium and chloride are usually high, which reflects the dehydration. The kidney function tests BUN and creatinine will show a specific ratio elevation that screams pre-renal failure.
Meaning the kidneys are okay structurally, they just aren't getting any blood delivered?
Correct. And then you have the smoking gun,
The acid level.
metabolic acidosis. You will see elevated lactate concentrations and a base deficit. That base deficit is effectively the chemical footprint of those starving tissues. It tells us how deep the oxygen debt is.
There was one point in the source material regarding blood counts that I found really counterintuitive. It's what I call the hemoglobin trap.
Ah, yes. This traps young doctors and medical students all the time.
Explain this. If I have a patient who is bleeding internally, say from a car accident, I would expect their red blood cell count, their hemoglobin to be low, but the text says initially it might be normal. How is that possible?
Think about a cup of coffee. If I pour out half the coffee, the amount of caffeine concentration in what's left in the cup is still the same.
Okay.
I just have less coffee overall.
Right, that makes sense.
Hemorrhage is the loss of whole blood. You are losing the plasma, which is the water, and the red blood cells, the solute, together. So the ratio of the percentage of cells looks normal in the remaining blood.
So it stays normal until when?
Until the body starts pulling water from the tissues to try and refill the pipes, or until we pump them full of saline. That's when dilution happens and the number drops.
So a normal hemoglobin count at the scene of an accident tells you absolutely nothing.
Correct. It does not rule out major bleeding. You have
Okay.
to treat the patient, not the number on the initial printout.
Mm-hmm.
If you wait for the hemoglobin to drop, the patient might be dead.
That is a dangerous little physiological trick. Moving on to part 3, the physics of oxygen. The source material gets pretty heavy into invasive monitoring here. It talks about the Swan-Ganz catheter.
The pulmonary artery catheter. This is old school, hardcore critical care. We thread a catheter through the right side of the heart, effectively into the lungs artery.
And what does that tell you?
It allows us to measure pressures inside the heart chambers and calculate the exact cardiac output. It gives us a real-time look at the engine's performance.
And this leads us to a concept that I think is the intellectual core of this deep dive, the relationship between oxygen delivery, or DO2, and oxygen consumption, VO2.
Right.
The text describes a shift from flow independence to flow dependence. Can we break that down?
Sure. Imagine a factory. In a normal economy, a healthy body supply trucks arrive constantly. The factory takes what it needs to run the machines and ignores the rest.
Okay.
If you send 100 trucks or 200 trucks, the factory produces the same amount. Its consumption is independent of the supply flow because it's already saturated.
I don't eat more just because the grocery store is fully stocked.
Exactly. But in shock, the economy crashes. The factory is starving. The machines are sputtering. Now, the factory is desperate.
It's in survival mode.
It is. So if one truck arrives, they use it instantly. If 2 arrive, they use both. Consumption becomes completely dependent on the flow.
So every single molecule of oxygen you deliver is immediately snatched up and used.
Yes, and this gives us a survival metric. If we treat a patient, give them fluids, oxygen, blood, and their oxygen consumption goes up, that's actually a good sign.
Why? I would think high consumption means high stress.
It means the cells are still alive enough to eat. It means the machinery hasn't rusted shut yet.
I see.
If we pump in oxygen and consumption stays low, it suggests the cells are too damaged to utilize the fuel. That usually signals irreversible shock and a much higher mortality.
It's not just about getting the package to the door. It's about whether the customer is still alive to open it.
That's a grim but accurate way to put it. We look at something called the oxygen extraction ratio. In shock, the body extracts everything it possibly can from the blood that passes by.
So we've diagnosed it. We know the engine is failing. We know the tissues are starving. Now we have to fix it. Part 4, resuscitation. Step 1 seems surprisingly simple. Fill the tank.
The fluid strategy. The golden rule here is to get the mean arterial pressure, or MAP, above 65 millimeters of mercury.
And the tool for this is basically salt water.
Essentially, yes. We use crystalloids, isotonic solutions like 0.9% sodium chloride normal saline or lactated ringers. They're the workhorse.
Why these? Why not something more high-tech?
They are cheap, they are compatible with most drugs, and they work. But they're inefficient. The source notes that to normalize a patient's volume, you might need 2 to 4 liters of saline.
That is a massive amount of fluid. That's like 2 big soda bottles straight into the veins.
It is. And the risk is that crystalloids don't stay in the veins. They are thin. They leak out into the tissues and, crucially, into the lungs.
So you can cause pulmonary edema.
You can drown the patient from the inside if you are too aggressive with the fluids.
This brings us to the controversy of colloids. These are the thick fluids, right? Albumin, hydroxyethyl starch.
Right.
The theory was that because they're thicker, they stay in the veins better.
That was the theory. Volume expanders. We thought, let's use large molecules so the fluid stays in the pipe. But the source material highlights a massive red flag here, specifically regarding hydroxyethyl starch.
The FDA black box warning?
Yes. In 2013, the FDA analyzed the data on this. They found that in critically ill patients, specifically those with sepsis, using hydroxyethyl starch didn't save them. In fact, it was associated with increased mortality and severe renal injury.
Wait, so the stuff designed to keep blood pressure up to save the kidneys actually destroyed the kidneys?
Correct. It essentially gummed up the works. It's a classic example of a good theory that had a terrible result in reality.
So what's the conclusion now?
The guidance is clear. Stick to crystalloids. Colloids are expensive, risky, and largely unnecessary.
What about actual blood? If someone is bleeding, saline doesn't help carry oxygen.
Right. If the shock is hemorrhagic, if they are actively bleeding, you must give blood. Saline restores pressure, but it doesn't carry oxygen. Only hemoglobin does that.
But blood isn't risk-free either.
No, it's not.
Yeah.
You can have transfusion reactions, infections.
Yeah.
The text also mentioned hypocalcemia as a risk.
That surprised me. Why would giving blood drop your calcium?
It's the storage chemistry. Blood in a bag needs an anticoagulant so it doesn't clot before you use it. We use citrate.
Okay.
Citrate is a preservative, but when you infuse that into a patient, the citrate binds to the calcium in their bloodstream. It locks it up.
It effectively sucks the calcium out of the system.
Yes. And since your heart relies on calcium to beat, a massive transfusion can cause cardiac instability. It's just another variable you have to juggle. You give blood to save them, but you have to watch the calcium to make sure the heart doesn't stop.
Okay, so we've poured in the fluids, we've filled the tank. But let's say the patient is in septic shock. The pipes are still too wide. The pressure is still low. Now we move to phase 2, pharmacologic warfare.
The vasopressors. These are the drugs that tighten the blood vessels.
But first, a major rule regarding hypovolemic shock. The empty tank scenario.
Never use vasopressors if the tank is empty.
Why? I mean, squeezing raises pressure, right? That seems logical.
Imagine you have a dry sponge. Squeezing it harder won't get any more water out of it. In hypovolemic shock, the body is already naturally squeezed to the max.
I see.
If you add powerful drugs to squeeze the vessels even tighter, you might clamp them shut entirely. You stop circulation to the organs completely. You kill the patient.
So fluids first. Always.
You must fill the tank first.
Okay. But assuming the tank is full and the pressure is low like in sepsis, what is our weapon of choice?
Thorcin. This is the king of the ICU. It's the preferred initial vasopressor.
Why is it preferred over something like adrenaline?
It hits the perfect Goldilocks zone. Norepinephrine stimulates alpha receptors, which causes that strong squeeze on the pipes. But it also has just enough beta receptor activity to give the heart a little kick.
So it raises blood pressure without making the heart rate go absolutely crazy.
Exactly, it's efficient.
So what about epinephrine? Adrenaline, that's the movie drug. Get me the epi.
Epinephrine is the alternative. It's a sledgehammer. It squeezes hard, and it whips the heart to beat faster and harder.
But it comes with baggage.
What kind of baggage?
It causes tachydysrhythmias, dangerous heart rhythms. It increases lactate production, which confuses our monitoring. And it can actually reduce blood flow to the gut. We use it, but usually only if norepinephrine isn't getting the job done.
The text also lists phenylephrine.
Phenylephrine is pure alpha. All squeeze, no pump. It doesn't touch the heart rate.
So when would you use that?
You'd use that when the patient is hypotensive, but their heart is already racing at 140 beats per minute. If you give them epi or norepi, you might push the heart rate too high. Phenylephrine tightens the pipes without revving the engine. And dopamine. I feel like I used to hear about dopamine constantly in medical dramas. Start a dopamine drip.
Dopamine has fallen from grace. The source is very clear. It is no longer the first choice.
Why the demotion?
It's a dirty drug. It hits different receptors at different doses. To get a good blood pressure effect, you need high doses. But at those doses, it causes significant tachycardia and arrhythmias. It's just not as clean or effective as norepinephrine.
There's one more category here that sounds like a contradiction in terms. The inodilator, dobutamine.
Dobutamine is fascinating. It's a positive inotrope. It makes the heart muscle contract with more force, but it is also a vasodilator. It opens the pipes.
So it revs the engine but relaxes the hose. Why would you want that?
We use this in cardiogenic shock, where the heart is weak. We need to help the heart pump, but we also want to reduce the resistance it has to pump against. By opening the vessels, we make it easier for the weak heart to eject blood.
But if it opens the vessels, doesn't pressure drop?
It can. That's the risk. You often have to pair dobutamine with a vasopressor, like norepinephrine. One drug to squeeze the pipes, one drug to kick the heart. It's a chemical balancing act.
And finally, vasopressin.
The add-on. Vasopressin is a hormone, not a catecholamine like the others. It works on completely different receptors.
You add it to the mix.
We usually add it to norepinephrine to spare the dose. It allows us to back off the other drugs while maintaining pressure. But you have to be careful. High doses can clamp down the coronary arteries and cause a heart attack.
It sounds like you are mixing a very dangerous cocktail, minute by minute.
It is a minute-by-minute titration. You are watching the monitor, adjusting the drip rate, watching the urine output, adjusting again.
What happens if you throw the kitchen sink at them? Fluids, norep, vasopressin, and they are still crashing. The text mentions a last resort.
Corticosteroids, specifically hydrocortisone.
Steroids. I thought that was for inflammation.
It is, but the theory here is something called relative adrenal insufficiency. In severe septic shock, the body has been so stressed for so long that the adrenal glands, which produce our natural stress hormones like cortisol, might just burn out. They stop working.
So we supplement them.
We give a 7-day course of hydrocortisone. It doesn't cure the infection, but it stabilizes the blood pressure and helps us wean the patient off the vasopressor sooner.
So how do we know when we've won? We're watching the monitors, adjusting the dials. What does victory look like?
We look for the reversal of those warning signs. We want the MAP consistently above 65. We want the systemic vascular resistance to normalize. But the biggest sign is the kidneys.
The urine output.
Yes. If the patient starts making urine greater than 0.5 milliliter per kilogram per hour, it means the kidneys are getting blood. The siege is lifting.
But there is a warning here about overwinning, about volume overload.
Right. We spend 24 hours desperately pouring fluids in. But once the heart recovers and the kidneys wake up, all that fluid has to go somewhere.
So you can go too far.
You can. If we aren't careful, the patient swells up, the lungs fill with water, and we trade shock for heart failure.
So the strategy pivots completely.
Immediately. We switch from fill to drain. We use loop diuretics like furosemide to unload the volume. It's a pendulum. You have to push it one way to save their life and then pull it back to keep them alive.
It really is a mechanical balancing act. You are manually piloting the body's systems. Fill the tank, squeeze the pipes, boost the pump.
It is. It's physiology in action.
Before we wrap up, there was one provocative thought in the source material that really stuck with me. It questioned the very goal of treatment.
The concept of supernormal goals.
Right. The text suggests that aiming for normal numbers, like a textbook blood pressure or cardiac output, might actually be wrong for these patients.
It's a profound question. We are trained to fix the numbers, make the screen look green.
Right.
but a patient in septic shock is in a hypermetabolic state. Their engine is running red hot. They might actually need higher flow and higher pressure than a healthy person just to penetrate those clamped down swollen tissues.
So by treating them to normal, we might be undertreating the specific crisis they are in.
Exactly. In deep crisis, the body might rewrite its own rule book. The question becomes, are we treating the patient or are we treating the monitor? The best clinicians know that sometimes to save a life, you have to ignore the normal range and give the body what it's screaming for.
That is something to think about. The map is not the territory.
Never.
Thank you for taking us through the mechanics of survival. It's a lot to process, but it makes you appreciate the incredible complexity of the work going on in the ICU every day.
It's my pleasure. It's a fascinating field.
And thank you to everyone listening. Stay curious, stay informed, and we'll see you on the next Deep Dive.